and we are better than ever. We are just waiting on our good friend Christine Hall to jump on and join us. She is just learning how to use a computer for the very first time, and she should be. I'm just kidding, Christine. She should be joining us here in just a minute. Anyways, we are back. I am so excited to be surrounded thus far by four of my very good friends. The fifth musketeer should be here any moment now. Uh, I am very well rested, rejuvenated, and ready to tackle the world of auditing, coding, billing, and compliance with my fearless caped crusaders. Um, I like the Justice League better than I like the Avengers. So I don't know.
No,
We'll be the.
no, I'm Team Avengers.
Are you Team Avengers?
Yes,
I
yes.
like the Justice League, although it hasn't been the same ever since the Wonder Twins aren't really
There
around
we
anymore. I
go.
don't
The
think.
Wonder Twins activate. Okay,
Yeah.
here we go.
No, I
Enough of
like the
that.
Super Friends. I'm the 70s gal.
Super
Yeah, yeah,
Friends.
yeah.
I'm
All
Wonder
right,
Woman.
here we go. So we have a great lineup of discussions today, and I think one that I want to talk about, Terry, is um, first the one that you talked about, which is the global code. Um, and I think you brought up a very good point because I think a lot of folks hear the global code and they automatically think about the global surgical period, and
Yeah,
that's not what we're talking about.
no.
So, what are we talking about?
Well, and a lot of times I bring these up so Paul can have some comic relief during his day because I know he probably deals with it as well. One of the things that comes up, not just in auditing, but in our training and our educating of providers and also staff, is when you are providing services from place of service 11, your office, and you are billing for, let's say, x-rays, or you're billing for nuclear studies, or whatever it is that are imaging, let's say, you are billing what we call the global fee, meaning that the global codes that are in the radiology section have two components to them, and some codes in the medicine section as well. They have a technical and they have a professional, meaning that there is a portion of that code from the RVU perspective that is the value that is attributed to owning the equipment, the safety, upkeep, all that. And then there's another percentage, and usually it's about a 70-30. It's a little different. 30% about is the professional component, or what we like to call the interpretation and the report generation and all that. If you don't put a modifier on it, differentiating those things, because you wouldn't if it's in your office, you would bill it as a global service. It has nothing to do with global days of surgery. You'd bill it just in totality, I guess is the way to put it. Then you are inclusive of everything you need. And we keep getting providers saying, well, how do I bill for my interpretation? It's in the code, it's already there. It would be like, baking a cake and including all your ingredients and then saying, well, how do I, also get paid for the eggs? I'm like, it's in your cake. It's already there. They're like, yeah, but how do I still get that? How about my baking soda? It's already in there. Okay. So everything's inclusive when you're billing it from your office. So I think sometimes that gets lost where the providers feel like there should be an extra code or an extra fee or an extra something reimbursement when it's already included in the service. The second thing I want to bring up on that is that if unless you have a payer specifically asking you to break it down, and there are Medicaid payers that want it broken down, there's a couple of Blue Cross that want it, TC technical and 26 professional, they do like that. And if it is I always bring up nuclear because I'm strong cardiology. Sometimes if you don't have the nuclear physician, one who's certified to read nuclear services, then you have to break it down. Then that's fine. But they think that you're going to get more by the more codes you have. It's the same reimbursement. You're not getting more. And it also isn't compliant. I know Christine and I did a joint nuclear review on for a client, and we how many times do we try to tell them in 5 different published guidance that you can't do that, you can't keep breaking it down, and it also can look like you're trying to get something by the payer. So be very cautious with that. It just sometimes I think something's missed in the light bulb hasn't gone off in understanding how all that works.
So, Terry, I know I've seen as well where practices are trying to do that because essentially one provider's like, well, I ordered that. I should get credit for the
Oh my gosh.
interpretation,
Yes.
but yet they may not be the one doing it, or they want to wait. They're out of the office for a week. They want to wait a week to be able to do the interpretation, but they want to bill out the study. And, that becomes very problematic as well because, like you said, we shouldn't be breaking things apart. And, we've had this issue with, rheumatology, for example, with their infusions. They want credit for the fact that they ordered the infusion, but they weren't there supervising. So, to some extent, you have to look at the workflow and see if that's something that needs to be taken care of through, other means. Typically, I just say, with the financial department, more so on the back end.
Well,
But
and
making sure
Stephanie,
you're not trying to double dip in any way as well.
well, you and I have had conversations with providers, a joint conversation, because the one thing that, and you brought it up, and it's a really good point. If you were trying to get paid for being the ordering physician, you're going down a road you don't want to go down, because doesn't that look like that you're going to order all kinds of tests just so you can get reimbursed for that? There's got to be some stark issue there. I'll leave that to the experts on that, but you can't you can't get payment for a referral. So, and that's really what the ordering is. You can't get paid for referring, for ordering. It has to be medically necessary, medically indicated and appropriate, and not just ordered so that you can make up some reimbursement in your practice. And when I heard that from the group we were talking to, I was just like, I mean, the face plant isn't hard enough how much I hit the brick wall there. It's crazy when I see that. Paul, I'm going to ask you on this one. When you look at this from a compliance perspective in some of your, clients, how do you get them to understand that the practice gets a certain profit margin on this stuff, but trying to get it for individual ordering physicians and all that is going down a road that's probably not a good idea.
Well, let's start with the obvious. I'm old and I've been doing this for a long time. And what you tend to see when younger providers come into the system is that the cycle of pain resets. Things that you spent years and years teaching and things that seem to be rote or very obvious, suddenly you have a brand new group of providers who are hitting the practice cement and instead of walking, they're hitting it much like a watermelon off a five-story tower. It's just, sometimes it's just going back to the basics and explaining exactly what they're doing, not in an accusatory way, but just, every coach has fundamentals, and if you do the little things right, the big things take care of themselves. And I know Christine has some thoughts on this as well.
Thanks, Paul. You're supporting my non-interrupting. I'm working really hard on non-interrupting. Thanks. So yeah, I do have a lot of thoughts about this. So the first thing is, it's frustrating for us, but I can only imagine it's got to be frustrating for the providers as well, because when they're in residency and they're in fellowship at the hospital, they're told, make sure you scan all the equipment that is used because we need to get reimbursement for all the tools and blah, blah, blah. And, they're taught a very different way of reporting services. And then they come into the pro fee world and they start using CPT codes, and no one ever stops to say, hey, watch out, buddy. The status indicators, the RVUs already account for how you're going to get paid, if you can delegate the service, what's included in it. And that explanation never happens. So we find that we spend a lot of time explaining that to providers, and it's frustrating for them because they were taught something so different from their peers.
That sounds like when the doctor goes into private practice and all of a sudden they're coming in and joining a practice, and you always hear, well, when I was at Mayo Clinic, when I was at Baylor Hospital, when I was at, and again, yeah, you're like, I don't care what you did in the past. This is what we do here, Yeah.
So, one of the things, and I think this is a brilliant conversation because I think it ties into some of the other things that we're seeing, right? So we're talking about getting back to the basics. We're talking about re-education, reprogramming, all these things. And we're talking about older providers, or we're talking about providers that aren't necessarily older, but have been established in the healthcare arena for 10 years, 15 years, 20 years. And I think what happens is we get a lot of compounding factors that come into play, right? We get, for example, compliance fatigue. I think, again, providers, healthcare professionals, organizations, we are facing constant barrages of regulatory updates, which again drive practices to not being able to keep up with some of this stuff. It can lead to a reduced diligence within these organizations and a higher risk of potential violations. I think you look at another compounding factor to what we're talking about, Terry, Christine, financial strain. Think about this. How many practices have undergone these audits where they're having to seek outside counsel from people like Stephanie or from Terry or Christine or Paul, Scott, myself? These are costly. And we're always advocating for providers to do things correctly up front, but it doesn't take away the fact that there's misapplication, misunderstanding, a lack of competency at the different payers, the different contracted entities to the federal payer programs, looking at some of these providers and making their own mistakes. I mean, Paul, you and I have done how many TPEs where the outcomes were absolutely horrific, but when we get onto the call with the nurse educator, they can't support anything that they said was wrong, and we actually have a 180 in return. And the last thing that I'll talk about is what we were just talking to. There has become a very heavy reliance on third parties, for specialized services, right? The reliance on billing companies, onshore, offshore. You're finding, Scott, just like you and I have been working on, all of these different skin substitute companies that have these quote unquote specialized coders that work for them, giving information that's specific to this brand, but might not necessarily comply with what the actual guidelines are. And didn't we just see an update to the skin substitutes? What is it? 74 pages of LCD information. It's insane. It's a very well written LCD. It's very well written because it has a lot of clinical study information in there. But the last thing that I'll say is this. The other thing that is so important, and I think the relevance to podcasts like this one, to what Stephanie is doing, to what Terry is doing, the relevance is the heightened increase of regulatory scrutiny on providers and hospitals. And hospitals better pay very close attention, because January of this year, and this is extremely rare, we had one of the first ever criminal indictments of a hospital in January of this year. And it was Chesapeake Regional Medical Center. This is unheard of. So, y'all, this stuff isn't going away. It's not going to get any easier. It's not going to get any more fun. The accountability, the gauntlet has been laid down, and providers, their staff, leadership, those in a position that handle the coding, billing of the services, the compliance of the organization, you're going to be held accountable.
Yeah,
And you
Sean,
got to
the
be
one thing
prepared.
that,
Go ahead,
that
Terry, please.
the one thing that you're, and it's alluding to what you said, but I think that we all see is that nobody seems to get their wake up call in time. It seems like, I
100%.
mean, for example, and this will lead into our next topic. We're looking at a shutdown Wednesday of the government, which will potentially end telehealth as we know it. It'll, 85% of people who on Medicare will no longer be eligible. It will stop the hospital at home. The rural health community is supposed to get $40 billion. That could shut down. And yes, I did hear just 20 minutes ago that finally there is a leadership meeting later today, or tomorrow, I should say, or tomorrow. Yeah, tomorrow, the 30th. But the one thing that is interesting is that, and Stephanie and I just did a telehealth. I know Christine did a telehealth recently. We still hear people going, telehealth could be a problem. And it's like, dude, people, it's in a couple days. Or, I mentioned to Sean not long ago, how many of you guys still have people saying, how come I can't get consults paid by Medicare? That's my funniest thing I hear people say. And I'm like, well, because in 2010, Medicare decided not to recognize the code. And I'm not trying to be flip here. I'm just saying that it seems like everyone has, tunnel vision on their job and just going around and doing it every day. And then all of a sudden they happen to open something on on their computer or whatever, or they hear from somebody who said. And then all of a sudden they come to one of us, or they come to somebody and say, really, we have an issue coming up. And so, to your point, Sean, and I want to send it over to Scott because I know he deals with this. I mean, how do people just not get updated in the moment? I mean, Medicare doesn't update once a year, doesn't update 6 months, doesn't update every quarter. They update every day.
It's continuous.
So you have to know what's going on. And Scott, how do you deal with this in your audits?
In my audits, I try to make sure I'm on top of the latest compliance
Should say your
information.
education.
Yeah, and we try to make sure that they understand both what's happening and what the implications are of what's happening, right? And so, we've talked about a lot of topics, and if it's 26 in TC, it's like, is it a provider-based clinic? Is it a regular clinic? Like telehealth, my guess is that the majority of physician practices have people scheduled on Wednesday as though nothing is happening and nothing has changed. And, we have groups that we work with who have organized their entire operation around the provision of telehealth. Behavioral health is a big area for that. And to be fair, behavioral health may not get impacted in quite the same way as some others, but we have providers who you tell them about these potential telehealth changes, and they're just like, they almost turn into like an infant, right? Like, what do I do? Like, how do I see patients? Like, I don't have an office anymore. My patients are 80 miles away. And, what I would say from a compliance perspective, it's a general statement, right? These are businesses, and if you open up a business of any kind, you have to understand the fundamentals of your own business, right? Like if I opened up like a convenience store, I would have to understand like, what do I need to do to sell scratch tickets? Like, where do I get like milk? If it goes sour, do I get like a credit? How much do I order? If I open up a Jiffy Lube, I have to know like what kind of oil goes into what cars. And it's no different in this industry. The primary difference, if any, is that we're in like this fast evolving regulatory environment, and we're in a somewhat irrational regulatory period, right? Like we've had this telehealth extension, like the government might shut down, and people should understand, if they take away one thing from this podcast, is like your telehealth cash flow may be interrupted significantly, like in 2 days. So
go ahead, finish your thoughts, Scott. I'm sorry.
Yeah, so I just think it's important to be on top of those compliance things as they directly impact you, and not just assume that nothing changes.
Yep, perfect. So I want to switch over to the conversation of telehealth, because I really want to spend the time that we have left on this podcast really talking about this. But before we do, I want to. I am not the telehealth expert, right? I know enough about telehealth to be able to have a semi-intelligent conversation and not to embarrass myself on the evolution of telehealth in our industry to where we are right now. But the intricacies of place of service, the originating site, all of those different things. But I want to talk about, and if we can, I want to talk about, because I think there's a huge misperception on how the rules for traditional Medicare Part B and the rules or the guidelines, if you will, for Medicare Part C are inherently different. They are not the same thing. Now, we have statutory guidelines, regulations that require the third party administrators, the Blues, the Uniteds, the Humanas, acting as a third party administrator for CMS to ensure that they pay for all services that are statutorily covered under Medicare Part B. That is their obligation. But what we are seeing is a huge departure from that. And I'm seeing a lot of post payment reviews. I'm seeing prepayment audits where these third party administrators under Medicare Part C are non compliant with the requirements for how to process claims or to adjudicate claims for telehealth services. So I don't care where we start this conversation, Stephanie, Terry, Christine, but I would like for you all to please integrate the discussion. And more specifically, I also want to integrate part of the discussion around the prescribing of durable medical equipment and prosthetics, orthotics. I know Christine's rolling her eyes and she's doing that head bob, but this is an area of significant vulnerability. And once you guys start talking, I'm going to see how surprised you guys are when I throw some statistics at you and I throw some information at you that is not universally known. So, however you want to start this thing, have at it.
Well, Christine, didn't you say you just got something from the Telehealth Resource Center? Let's start there. What did you get?
Yeah, so I've been on the workforce of the Southeastern Telehealth Resource Center for about 7-8 years now. And in the Southeastern region, Lloyd Simmons is our executive director, and he sent out an email this morning, again, just super concerned about the possibilities of what this shutdown might mean to telehealth. One thing he did say, though, that was hopeful was that what we may see is flexibilities giving some retroactive payment. Now, this is again totally theoretical. We haven't seen anything in writing, but because we know there's so many bills on the floor right now that need to be reviewed regarding telehealth, it is, I believe, the intent that we will continue to allow home. But like you said, because Congress has been so busy and because it has to go through congressional interventions in order to become permanent, and with the potential of these extensions not being carried out, the hope for me was that these flexibilities, as we've seen flexibilities in the past, will allow for retroactive billing. So we've got to keep our ears open and listen to see if any of those things are going to be discussed maybe at today's meeting, because that might be the saving grace. Is that hold it? We can't do anything about it, but maybe you can retroactive.
In California, they contradict that. So in California, I'm actually part of the Telehealth Resource Center in California for the last 10 years. And they just put out something this morning as well. And California, we're weird out here. I get it. I know it's California. What can I say? But they actually said, with ongoing political uncertainty and many competing priorities in Congress, there is an imminent, they didn't even put a real risk, imminent risk that lawmakers will not act in time, didn't even say May, to the telehealth policy cliff that would roll back policy gains. And they didn't mention anything about, retro auth. I just don't want to put in a head that everyone could get that. If it's a state issue, it could just be Medicaid potentially, Medicare. I don't know. I mean, all the things that we're seeing right now with the government infighting, which I'm kind of tired of it, just, get stuff done. It seems like it's more of a playing chicken and who's basically gonna blink first. Now tomorrow is the imminent deadline, tomorrow at midnight, and they have to figure it out. But the big thing that everyone needs to know, if they figure it out, and the continuing resolution that passed in the House is signed in or is approved by the Senate, which it has not been, it failed in the Senate. All this means is that the current status of telehealth would extend through November 21st. That's all it means. At first, I thought it was the 25th. It was revised. So it means 7 more weeks. That's it. So, and then the appropriations is now figuring out how what they want to do from a permanent perspective. So it's not like the CR is going to say, "Oh, take it down for permanent or take it down to the end of the year." No, it's we're just trying to get another 7 weeks. I almost feel like it's the PHE, waiting at the window. Let us know the Friday before. And so this is what we're looking for. Do we still get to do it through the third week of November? So keep this in mind because people that are listening to this podcast, for those of you that, and I know there's a lot, the public health emergency was over 5 years ago. So there's some of you that are in healthcare that don't even know what the pre-pandemic rules were. You don't know what an originating site is, where the patient is. You don't know what the distant site is, where the physician is. Scott and I had a fun exchange I think a year or two ago, about people trying to say everything's high risk, and we had a Little House on the Prairie reference. And so it was funny to me only because I think about that in terms of telehealth. Like Christine, her and I've been teaching telehealth for a good part 10, 15 years, not just since the public health emergency. So when it was the pre-pandemic rules, and the reason I say that is I was surprised prior to the public health emergency. So prior to the pandemic, some of the rules when I'm like, why do you only pay for patients at home if you're in a certain metropolitan area? Because, and they still, and it's only some, if they were house bedridden, they still had to go to a critical access hospital. They still had to go to an originating site. It wasn't all their home. So to me, it's like, well, that's dumb. I mean, and I'm trying to be professional about this, but it made no sense to me that, if you're going to do telehealth, let the patient not have to, get dressed, get in their car, go to a place. And the reason I brought up the Little House on the Prairie references, in my mind, these are rural patients that are in an area that just don't have opportunities or even transportation. I'm not saying the cart and buggy thing. I'm not going back that far, but just saying that, there might be an issue with just getting to a place that has an approved originating site. So,
Well, and I think the government, sorry, sorry, I cut you off.
no, please do. I could go on for this forever. It's
No,
crazy.
my feeling with telehealth prior to the pandemic was the government just never bothered to update the fundamentals of telehealth, even as your ability to receive telehealth prior to the pandemic was changing. Like, I think the original Medicare telehealth benefit was basically built around the notion that as a patient, maybe I live somewhere where I can't get to a cardiothoracic surgeon quickly, right? And so the whole idea is, well, I'm sick enough, I have to go to the hospital or I have to go to this healthcare facility, but we can't get a cardiothoracic surgeon out here in like Kalispell or wherever I might be. So we'll bring one in on a screen. And it really never contemplated the idea that like a patient at home may just have mobility challenges with getting to the doctor. And it may just be easier for them to see their primary care provider. And so, the pandemic, as I'll always say about the pandemic, by the way, the Little House on the Prairie reference was when a pediatrician told me that otitis media was life threatening.
I know. I have those too. I thought it was funny when we went back and forth on that.
And when we got to the pandemic, it was like all these things that like nobody could fathom us doing, right? Like people working at home, like people seeing the doctor at home, like walking down the street and drinking, like all these things that we couldn't do were suddenly like, well, let's go ahead and do these things. And now it's time for the government to catch up. And the thing that I'll be curious about in the event, as it seems possible that there's an interruption in the telehealth benefits as they're currently written, is it's going to inconvenience potentially like the biggest block of people who tend to be regarded as like voters who
Yeah.
want their stuff to be taken care of, right? Like I think a lot of us in life, these individual things that happen, you may say, well, that's good for the country or it's bad for the country, but doesn't necessarily affect me like right immediately, right? But there's a lot of Medicare patients who will suddenly have their doctor's appointments canceled, who may at that point engage with their legislators. So, I'll be curious to see what happens in the event of an interruption like this, because I mean, my opinion is it's pretty silly, right? Like, we have this technology, we have the capability to do it. I understand some of the things that have changed to address what I felt were situations where people were maybe taking advantage, like the provider you work with who wants to do 3 phone calls on the drive home and like bill for those. And so now we can't really do that anymore, right? You have to have the video equipment available. And so I think like I think we have some work to do as a, I guess, taxpayer, to figure out how these services are utilized appropriately. But to just pull them away and say, well, you have to drive to this facility, it doesn't seem very smart to me.
Well, the one thing we're going to run into, and I was Christine and Stephanie, I brought them in over the weekend saying, okay, I've had this question from a client, and that it's like, oh, this is interesting. So, maybe to the fellas here, you guys can comment on this for us too. And I think Christine had an interesting perspective, and she's probably correct. Stephanie had a perspective as well. And then of course I'm like, well, here's mine. And it was all three of us had a different perspective based on the Medicare rules that are a little gray in this area. And it's, what if patients still want to keep it? Let's say it goes away. Let's just play devil's advocate, and they want to pay cash. Well, is it a non-covered service? No, it's covered. You just aren't eligible because of geographic location you're in. Is it something they can sign a waiver? No, not necessarily, because that means it's still medically necessary. This means it wasn't medically necessary or it wasn't covered. But there is a whole list. Stephanie pulled it up of what you can charge cash to Medicare patients. And does this mean now you're denying care or telling them to get it elsewhere? Or so there's this gray, elephant in the room of, how do they get it if it's not a covered service, and can you charge them? And Scott and Paul, this is a problem.
The only thing I could think of for that is, as a patient, at least as I understand it, as a patient, I have the right to tell the provider that I wish to not use my benefits for something that's covered or not, right?
Not
Like,
in
I have the right to,
Medicare.
I believe I have the right in Medicare to say
No,
that I
you
don't want a
don't.
claim to be
Not if you're a
filed.
participating provider. It's kind of like if you are arrested and you ask for a lawyer, you don't have any rights after that until your lawyer comes. You can't say, I changed my mind. You can't do it. It stops at that point. You get a lawyer. They can't ask you anything. There's nothing you can do. You ask for it. So it's very similar to that kind of thing where you don't actually, under traditional Medicare, you don't have that right now. Under Medicare Advantage, Sean wanted us to bring that in.
Yeah.
That's a little different because that's commercial plan. So that's now policy. That's, you could get something from that actual payer to say that, you have that option. But under traditional Medicare, and Christine, correct me if I'm wrong, everything I read says you can't send that out. Now, if it's a limiting charge, so it's a physician who doesn't participate in Medicare, yes, they can now, you have a charge, you can have a cash charge. It's a little different rules. I'm not up on all of it, but it does
and it's
have
very
some
particular, Terry. If
Yeah.
if you're not par, but you have nurse practitioners or a lab
Right,
or
right.
Medicaid,
What if you
Medicare.
have
Like, there's
secondary?
some
Yeah,
very strict particulars about who can use limiting charge and who can't use limiting charge. So
right. It's
hopefully you've got a savvy office manager.
you definitely have people that need to know what to do in that scenario. And honestly, I think I hate to call it lawyer up, but I think you need to have as much documentation and as much information. And for me, now this is just me, this is just a personal professional opinion. If it's just for the convenience of the patient, I would frown on allowing it.
I
If it's
agree with you 100%.
Sean, I think it has to be
Yes.
medically indicated that the patient, it would be a harm to them if they had to figure out how to come in
Right.
and deny, access.
So I think there's a couple of things, right? One, obviously, you have to look at the clinical judgment of the provider, and the clinical judgment of the provider means that they are looking at all of the mitigating circumstances. They're looking at the patient's overall episodic care, and they're making a determination based on their mobility issues, based on their repressed or depressed immune system, as to whether or not coming into the office is safe and prudent for the patient. There's a lot of different things. But I asked the question about DME POS, right? And I want to ask you guys sort of, I don't want to call it a leading question, but I want to ask this question, okay? So if I said to you, when I am conducting an audit, and this is for the whole panel, when I'm conducting an audit or you're conducting an audit, when we talk about medical necessity, okay, we define medical necessity as those services that are performed in accordance with generally accepted standards of medical practice, right? Now, what does that mean? We're talking about services that are not experimental and or investigational. We're talking about services that have been peer reviewed, but we are talking about primarily what a clinical provider, an MD, DO, NP, PA, any of the other credential eligible providers with insurance companies determine is the best course of care for the patient, right? That's how I define medical necessity. But we've seen a huge uptick during the public health emergency with the prescribing of DME. And we've seen a lot of telefraud. And now there's very specific ways that practices were supposed to go about setting up, and the utilization of marketing companies, the fact that you couldn't call them, you couldn't solicit them, they had to call in, they had to acknowledge that they called in, all these different things. But if I asked you, and this is open to the panel, if you were conducting an audit, and let's just say there were 10 patients, and of the 10 patients, 9 of those patients all had telehealth services where they were connected to a provider in their local area. The provider did a comprehensive history on them, did as much of a objective review as they could, right? Because we're limited based on telehealth. So really it's only what we can visualize or what we can hear. And then the provider said, based on the fact that the patient has undergone conservative measures, NSAIDs, Tylenol, pain medications, the patient went through physical therapy, these things weren't, as prescribed, necessarily beneficial for the patient. But I believe putting an ankle brace onto the patient or putting a hinged elbow brace onto the patient for mobility purposes, or putting them into a sling or some other type of DME is clinically relevant and appropriate based on their past treatment plans. How would you view the prescribing of the DME by that telehealth provider? And I ask this because this is a huge issue right now. We've seen a lot of cases previously, right? Paul, you and I, Scott, you and I, Christine, Stephanie, Terry, we've seen these. Give me your feedback on this, because this is a huge issue. And then I want to talk about the really, the nuts and bolts of how different Medicare Part B is versus what's going on in these Medicare Advantage plans. So whoever wants to jump on this first, please. Stephanie, you've been pretty quiet.
Yes. All right, I'll take a stab at it here. So, as you're talking through it, Sean, I'm thinking, okay, what about documentation? So, is the practitioner who is ordering that DME, are they showing us the full scope of that? I have a lot of issues now, especially you had mentioned the skin substitutes, where we can't clearly see conservative care. But my other thought is, when we're thinking about telehealth, is this a flyby? Like, what is this practitioner's involvement with the patient? And I know that that's been the problem that I've seen a lot, because we have issues where, let's say, Dr. John Smith opened telehealth and he's going to do only DME for the elbow braces. Okay, well, who found all of those patients? Who did he connect with that he knew that he had a stream of people coming in only for elbow braces? And then on top of it, what was actually done prior? How much of it can be traced? And one of the things I found interesting, not necessarily in OIG reports related to this, but one thing that I've seen that the OIG is calling out a lot recently is about that history. and not just a one-time touch with the patient. So, you already have someone who maybe that's a new patient. They're coming through telehealth. This is a physical problem, so how much do they really know and what access do they have to records before? All of that would heavily play into the way that I'm looking at that, just because we know medical necessity is so subjective. And I know a lot of the the records I read for various reasons, a lot of times we can't see that in there.
It's a very
I
good
have an
point.
example for you, Stephanie. I have a urogynecology provider who only sees her patients initially through telehealth. And the first time that she meets them is in the OR. I'm not kidding you. Prolapse, bladder slings, everything via telehealth. Where's the physiological data to support that that is even needed? Where did this even come from? Because these visits, a lot of these visits are macro based. Patient was explained, patient had, and they're giving us more educational information than actual physiological information or true data. And so I think that as it results into a DME or like this one, a possible surgical experience, there needs to be more. There needs to be proof other than just the physician thinks that this might work, especially when there's these large costs that are associated with it.
Well, I also have met a lot of practices this year that are struggling with this because they opened up after the PHE. So they didn't know what it looked like before. They didn't know what it looked like during. They just knew, oh, you can do telehealth. That's all they know.
Oh,
Drives
this
me
is,
crazy.
I mean, they built entire business models around it.
Yeah.
I mean, one of the things, and Stephanie or Paul, you guys may remember this, you all may remember it. Like, we would get calls in the early part of the PHE from providers themselves, and they would basically say, like, this business of working at home is great. So I just want to leave my job and start a 100% telehealth. I remember this one PA, and she was very nice, but she was just like, I can do this coast to coast. I can do a nationwide, telehealth business. And, we sort of got on a path, right? And it's like, well, if the patient's in Missouri, you need to have a doctor within 20 miles of them throughout the visit. And in this state, it's this. And that example, Christine, I mean, my brain was doing what Terry's hands were doing. I was just like, is this a
Like, what?
possible like thing?
We're going through the matrix.
Like my concern, I read,
Dozens and dozens of patients, I'm seeing this.
I read this study years and years ago. I mean, I think it was before I was even at DM, and it was about like patients who had back pain and their complications and all that. And the one thing I took away from it that I always remembered was they were like, well, if the patient started with a surgeon, they tended to have surgery. If they started with a PT, they tended to have PT. If they started with a chiropractor, they tended to have chiropractic, and the outcomes were usually somewhat similar. And the back surgery had such a high rate of complication relative to the cost that oftentimes on second review, you would think it was unnecessary. And so using that analogy and going back to what Stephanie said, or using that example, like if somebody opened up a telehealth operation or whatever you want to call it, and their primary thing was the prescription or provision of DME, as a mildly interested statistics person, the first question I would ask is what percentage of the appointments resulted in DME? Because just logically speaking, they shouldn't all result in DME. And so if this just that, and I think you build in that example, like telehealth is somewhat interesting because in theory, right, like I could, do this and the provider has to try to make a determination about like whether or not I'm wincing and at what level. But if the sole purpose of this is just to facilitate DME, then that. But in theory, I could say the same thing about meloxicam or allergy meds and telehealth, right? Like if I just decided I'm just going to be the telehealth allergist, and everybody who calls and says, I'm started sneezing and it's March, just gets a prescription or just gets some kind of supply. It that's one of the reasons we can't have these nice things.
Well, and there's one good, I have an example. I just did an audit for a payer, a big payer, and they said, we have a problem with some of these diabetic shoes referrals. I'm like, and those are expensive. So they were sending them over to podiatrists from primary care offices. And you have to have the referral from the primary care provider that is following the patient physically. And a lot of patients saying that they needed it couldn't get into their primary care doctor's office. So this big payer said, well, we have panel telehealth providers. And so our telehealth providers can evaluate the patient and then send over a referral to the podiatrist to get it. So this happened with thousands of patients. And I'm like, okay, that doesn't make sense because that, again, that is a panel provider that has nothing on that patient, no history, no physical exam, nothing. Well, the payer denied all, sorry, denied all, it was amusing to me because it was so stupid. They denied all the services for the podiatrist to get the diabetic shoes because of that very concept, because their own panel providers didn't have the history or physical exam on the patient. I said, but you offered it. You approved the telehealth visit to then facilitate the referral. And they're like, yeah, but we shouldn't have. I'm just like, so what is it? What kind of opinion do you want me to give here? I agree. The patient needed to get into their primary care doctor's office, but you offered them a telehealth through your own company. And now you're denying the service. They're like, yeah, so we just want you to make sure that, you're deciding if it's medically necessary or not. And I'm like, you're not hearing me. You set this up to fail. You set this up to deny the services. And anyway, I took a huge issue with that payer. It'll be interesting if they call back. But it was just like you started it. I just it's interesting to me just when you see stuff like that from the telehealth perspective, you know, I, I, I don't know. One thing I wanted to mention, just going off topic a bit, you said something, Sean, about skin substitutes, and Stephanie, I know you guys.
Yeah.
I don't dive into that. It's not my thing, but there is a pilot program for prior
Right.
authorizations coming out for Medicare, and it's on the list, just so you know.
Well,
So
and
there's
it
5 services.
sorry,
That's one of them. Yeah.
it should be on the list.
Yeah, it
You
should
know,
be. I agree.
I think some of these things that we see with these skin substitutes where the patient has like a 2 millimeter incision on their knee and the person's 83 and we're worried about the quality of the scarring is crazy to me,
No,
frankly.
I agree. And this has been, the collagen bandages, the skin substitutes. These are areas where it has sort of been the Wild West. There is a company out there that does these collagen bandages, and they are absolutely one of the most reputable stand-up companies that I've worked with. They do a tremendous job monitoring the documentation, educating the providers to ensure that they are documenting the wound sizes, the depth, the width, the length, talking about light to moderate exuit, ensuring that these things are prescribed after surgery, not prior to surgery, making sure that they're not prescribed for somebody who had carpal tunnel surgery.
So
I
they
mean,
don't
yeah.
tell the patient to delay home health by one day to get all their orders in.
No, they do not.
Oh my
And
gosh.
we will, yes, yes.
Jeez. Sean, you
But
had a question in the comments that said, what are consultants telling providers about telehealth right now? Well, for me, I'm saying
yeah,
I would not schedule a telehealth visit for traditional Medicare patients or Medicaid, unless, that's okay with their policy if they plan to extend on their own. But for traditional, until we know
And,
what happens,
well,
October 1st, you'll know.
Mhm.
yeah,
and one circle I wanted to close from before, I mean, and this is just, I guess, another negative commentary on why all this happens is I don't think you can or should rely on getting a potential retroactive payment for
I
some. I
agree.
mean,
Yeah.
if you get it, that's great,
Who? Right.
but I wouldn't count on that.
No,
Yeah.
no, I
The
wouldn't either.
the
go
other
ahead,
thing
Paul.
I might add is, I would try as best I could as a provider to restrict services within your state lines.
Yes,
One thing that we really haven't discussed because it's not particularly a Medicare Medicaid issue is the issue of female reproductive services and how this has blown up, really, telehealth cooperation between states. Because there are literally doctors in New York who are under indictment in Louisiana right now for giving out RU486, and mifepristone. So, it as best you can try to keep it within your state, knowing that whenever you defragment something, in the same way that Windows used to have a disk defragmenter program to try and bring things together, there's really no way to close Pandora's box at this point as far as the level of non-cooperation between certain states.
Well, and I know, Scott, you're going to get into the place of service thing on telehealth. I know you wanted to mention it, but I wanted to mention something else that I can't even believe I have to mention this. I think Sean and I talked about this recently too. You don't have the option to go against regulation. And here's what I mean by that. I'm still auditing records where it's a telehealth service. It may or may not have been appropriate to have. But then all of a sudden, I see in there that the patient can't connect to their HIPAA protected platform they're going to use, whether it be the EMR or a platform that, again, the provider's paying for. And so there is a statement in there saying the patient understands that or says that they can't connect to, let's say it's Epic Iris, and they can't connect to it. And so we're going to go ahead and do this through FaceTime today, and we know there is no HIPAA protection. The Office of Civil Rights said stop doing that on August 9th, 2023. You don't have the right to go back and say to the patient, either one of you, the patient can't do it, you can't do it as a provider, and say, yeah, but we both agree that we know it's not HIPAA protected. That's okay. No, there's no public health emergency. There's no regulation that says today you can do that. You cannot do that. Absolutely cannot. And just then to lead into Scott, so for his place of service, Scott, when you talk about that, can you talk about not going through a drive-through of Starbucks and having your telehealth service and thinking that's okay?
I would definitely not do that. I would at least, get my coffee and park over in the corner somewhere so I have some privacy and not have the person in the window who may be able to contribute to the visit, right? The independent historian could be the Starbucks lady. I just saw the patient spill some coffee on her hand, and I'm giving you that history. No,
I had a doctor say that the patient put him on mute. She goes, "Hold on, I need to order." And
it's like those videos that you see sometimes where the person shows up for their virtual court date and they're like in sweatpants, and they got kids running around or something. Anyway, one of the biggest mistakes that we see in telehealth, that I see when I audit telehealth, is how the place of service and modifiers are conveyed. 11.10.2, Medicare has typically said for at least the last couple of years that you don't need to use a modifier because we have this place of service 10, place of service 2 for telehealth. But oftentimes I'm looking at telehealth notes and I'm seeing place of service 11. And so I'd say two things. Like, first of all, the removal of telehealth on October 1st, or restriction of it if it does happen, the solution is not to start billing these as place of service 11, because you will get paid for that. And you could potentially be accused of fraud at a later date, depending upon how all of this resolves. And, if you do get paid for using places of service 10 or 2, going back to the retroactive conversation before, like, I wouldn't assume that you're going to be able to keep that forever. Like, maybe you will, or maybe the payers will just not pay for those things. But you do need to be cognizant of how these services are getting billed, because you could find yourself in a worse situation if you have been historically billing your telehealth and you don't know the distinction of place of service, and you're getting paid for these things, and the payer just thinks you're not doing telehealth, and then it comes to pass later on that these were telehealth visits that were billed improperly.
So I want to leave you guys with, I don't want to leave you with this. I want to ask you this, and again, help me think through something, right? If I told you that there is a CERT study, right? And for those of you listening, you may have heard the term CERT. You may not necessarily know what it is. It's the comprehensive error rate testing. Okay. And this is purely data analysis. This is not audits. This is just determinations based on what has been submitted for claims review, what has passed, what has failed. The overall improper payment rate for the fiscal year 2024 for Medicare fee for service was 7.66%. Okay. Doesn't sound like a lot until you start to understand how many billions of dollars. We're talking $31.7 billion of improper payments. But think about this. 21.41% were durable medical equipment, prosthetics, orthotics, and supplies. Sure, there is a segment of the population that they're just not good people. They do bad things. They submit false claims. But that's a very small number, 0.5%, maybe less. Would you agree with me? Because I'm talking to people who are legitimate auditors. Terry, you're a legitimate auditor for governmental payers, for insurance companies. Christine, would you agree with me that the guidelines surrounding the ability to submit claims for DME POS are highly complicated, very difficult for providers and for beneficiaries to understand, and that the process for going through the prior authorizations, where some DME POS requires a prior auth where others don't, but then taking into consideration, if you bill to Medicare Part B, I believe it's CGS is who you bill to for DME POS, versus billing to the third-party administrators for Medicare Part C. This is not black and white. There are significant gaps in the process, in the rules, in the guidelines between these. And that's most likely what drives this high error rate. Would you agree with my hypothesis?
So, Sean, I have a
Please.
little bit of a different thought on this when we think
Please.
about the actual practitioner doing the prescribing versus manufacturers, distributors. And I personally feel like the manufacturers and distributors take advantage of the fact that our practitioners don't do enough of their own due diligence, because constantly we come across clients who are in trouble, they haven't done things correctly. We say, okay, well, there's an LCD. Did you look at it? What's an LCD? Have you ever had external audits before? No, I don't want to pay that money for that. I'm getting paid. My revenue's fine. What are you talking about? So, yes, things are very complicated, but it's at fault of our practitioners for thinking that they can be hands off, and it's the fault of these distributors and manufacturers who take advantage of the fact that they know that they're not going to dig into it and they're going to listen to them at their word.
And I agree with that. I think it's. Oh, Sean, you're muted.
I thought you were talking to your dog. I don't know.
No. But and I agree with you, Stephanie, but I also want to put out there that the payers have to assume at least 50% of the responsibility for not adhering to their own payment policy guidelines and for significant departures between what is under Part B versus what Part C drives.
Can I
Go ahead,
ask a
Scott,
question
please.
to everyone doing the DME? The thing I don't understand, and I'm somebody that I don't do a lot of DME, but I do a lot of where you in office, you're charging for isotopes and medicines and things that you're doing, injectables, things. You're not allowed to get more than your wholesale price of what you're doing. So why is DME such an issue? Are they making money at this? Because you can't inflate the price of it, right? What am I missing?
Well, doesn't that go back to whoever's selling it to them?
Well, it does. And you're actually going down a rabbit hole that would
Okay.
actually require another 30 minutes. You're on the right track, Terry.
Okay.
But DME POS is a PIA.
Well, and
a couple of you got that. It took a
Well,
minute.
I got it, and it's like, and the reason we're seeing the activity that we're seeing with the collagen dressings and the skin substitutes right now is there's clearly a sizable financial incentive between the cost of goods for these things and the reimbursement pool of money that's sitting out there, right? Like that's the reason we're seeing a surge in that and not a surge in like sugar tong splints or whatever. It's because they're going where the money is. And you know, I know we're kind of at our time. I think Stephanie made a good point, and I think there's a lot of hands in this process. So when we started getting all this audit activity around the collagen dressings, the DME was, or the LCD very specifically said at every follow-up visit there has to be updated measurements of the wound length, width, and depth, and any healing activity. And I don't think I ever saw that in those notes, right? And so the providers, you know, when you're taking, and I've said this a few different ways, when you're taking a big part of your financial eggs and putting them in a specific basket, regardless of what that basket is, you should have a pretty tight and clean understanding of how to perform those services. Now, we can then turn to the DME supplier, or the DME MAC rather, and say, well, these LCDs are written very horribly. Like a lot of these LCDs, you can't quite figure out if it's covered for this scenario or not. And sometimes that's as simple as whether they say and versus or versus like and or versus either versus shall versus must. And so, you know, these companies that want to create a financial, you know, windfall for themselves will play in the margin of those things. You know, like I made that comment before about the vendor who told the patient to delay DME, or to delay the start of home health for a day because they needed to get these supplies ordered so that they would be paid for under Part B. And when we gave the feedback to the client to not go down that path, this vendor had the audacity to say, well, that's how we demonstrate our compliance. We make sure our orders don't occur while the patient's on home health. And it's just, my head kind of exploded at that point.
All right. I want to say thank you all so much to Christine, Stephanie, Terry, Paul, Scott, for taking the time out of your very busy schedules to once again jump onto a Monday roundtable for auditing, coding, billing, and compliance. I want to thank each and every single one of you that either watched us live or listened to us live or are listening to us as a replay or a podcast episode on Spotify. Terry and I are going to be back tomorrow with a brand new #Terry Tuesday episode. I can't wait for her to stump me with another topic, as she loves to do. We'll be back in 2 weeks with another brand new Monday roundtable. So until then, remember, be good to yourself, but more importantly, y'all be good to each other.